Thank you for joining us today for this webinar on clinical diagnostic exome sequencing. We're going to be addressing clinical utility and cost effectiveness. I am Nancy Kramer. I'm a genetic counselor here at Ambry, where I work in the Department of Medical Affairs, helping with case coordination and assisting our clients in the clinical realm with coordination of testing. We're going to hear from two speakers today. The first will be Erick Lin, MD, PhD. He is the Director of Medical Affairs at Ambry Genetics. Dr. Lin completed his MD PhD training at Northwestern University's Feinberg School of Medicine. He then completed both his residency training in pathology and fellowship training in molecular genetic pathology at the UCLA David Geffen School of Medicine. At Ambry Genetics, his responsibilities include signing out Ambry's molecular diagnostic test reports, in addition to his work as Director of Medical Affairs. Dr. Lin will be providing us with an overview of clinical exome sequencing and the role of this test in the diagnostic process. We will also be joined by Julie Cohen. She is a genetic counselor at Kennedy Krieger Institute. Julie received her master's degree from the Johns Hopkins University National Human Genome Research Institute. In her current role, Julie provides care for patients and families with a wide range of neurogenetic disorders and developmental disabilities. Julie will be discussing the clinical utility and cost-effectiveness of exome sequencing through the discussion of several clinical cases that have benefited from access to this testing. To get us started, I would like to talk about how we identify an at-risk population and where clinical exome falls in the realm of genetic testing. As a disclaimer, both Nancy and Erick are employees of Ambry Genetics. It's tempting. Prior to joining Ambry, I spent more than a decade working at the Department of Medical Genetics at Cedars-Sinai Medical Center, and I was in the clinical setting. In that role, I worked with many patients with a variety of complex clinical presentations. It is tempting to think of genetics as an obscure academic subspecialty of medicine, but as a whole, these patients are not an insignificant segment of the patient population. Approximately 2 to 5% of infants are born with a major congenital anomaly, and these can have a variety of etiologies, including major single-gene disorders, chromosomal abnormalities, maternal factors, though often the etiology remains unknown. Approximately 3% of the population will be diagnosed with developmental disability. An etiology could be established in 40 to 60% of cases, though as we will see, testing is often complex, expensive, and stepwise. 1 in 90 individuals might be diagnosed with autism. The recurrence risk in SIBS approaches 20%, suggesting it's very likely that there's a genetic etiology. However, an actual genetic diagnosis is made in approximately only 15% of cases. And lastly, seizure disorders are very common. Up to 1% of all children up to age 14 may be diagnosed with a seizure disorder. Our causes are similarly diverse, as we've discussed. So as a whole, the thing that we consider rare diseases actually collectively affect more than 25 million people in the United States, are closing in on 1/10 of the total U.S. population. More than 70% of these individuals are children, and today, half of the children in pediatric genetics clinics do not have a definitive diagnosis. Over the last decade, we have entered the age of genomics. Our understanding of the genetic basis of many of these conditions has increased significantly. However, the expectations of our clients to provide them with meaningful discussions of diagnosis, prognosis, treatment, management, and recurrence risk have increased as well. Up to the year 2000, we could get a confirmed genetic diagnosis in only 15 to 20% of cases. However, this was often a lengthy diagnostic odyssey, requiring many, many tests over many, many years. In the year 2004, the technology to do microarray came on board. We were able to increase our diagnostic hit rate for chromosomal abnormalities from 2 to 3% to perhaps 10 to 15%. 11% is the average. And we were better able to understand that there are non-genetic causes and other genetic causes. However, when we start breaking apart, in particular, other genetic causes at the time of 2004, we still had many, many etiologies, and we're still in the realm of having to do stepwise testing. We had to diagnose patients using complicated testing strategies that required recognition by clinicians, identification of novel presentations, understanding of rare syndromes that may take years to complete. And it is on this background that we came to understand the value of whole exome sequencing. This has very quickly gained acceptance by the medical community, and this one test alone has given us a successful diagnosis in approximately 30% of cases. It has enabled us to move our segments of the pie and improve our diagnostic hit rate significantly. And it is on this background that I would like to hand the conversation off to Dr. Lin for a discussion of what whole exome sequencing is and how it is used.
Thank you very much, Nancy. And as Nancy alluded to earlier, I'll be presenting a high-level overview of exome testing. So given my background as a molecular pathologist, and I just wanted to present a general, introduction into what the exome is to kind of make sure that everyone is on the same page. So everyone knows that the human genome consists of 46 chromosomes, and multiple genes are interspersed throughout each of these chromosomes. Additionally, the structure of genes consists of both exons and introns, and the exome is comprised of all of the exons present in the genome. So what is the significance of the exome to human disease? So the exome comprises approximately 1% of the total genome, or about 30 megabases or 30 million base pairs of DNA. Though comprising a small fraction of the genome, mutations in the exome are thought to harbor up to 85% of mutations that could have a large effect or directly lead to disease. And of the 20,000 genes that comprise the exome, 4,000 of them are well characterized, as evidenced by some of these databases. For those of you who are not as familiar with the genetics field, HGMD stands for the Human Gene Mutation Database, and OMIM stands for the Online Mendelian Inheritance and Man Database. And for the remaining 16,000 genes, there are tremendous potentials for disease implications. Next, I want to talk about some of the general pathways for exome testing. So exome testing is an available testing option for many different types of patients, as well as many different clinical presentations. I'll go through some of the typical workflows that happen in genetics clinics. So after the initial clinical evaluation, that includes medical history, family history, symptom evaluation, chromosomal microarray analysis may be performed. Additionally, targeted genetic analysis, such as individual single gene tests or gene panels, may be performed. And in these cases, if these subsequent testing are not informative, follow-up option is to actually perform exome testing to analyze all 20,000 genes concurrently. And in certain cases, if there are no single gene tests available or you have a very complicated phenotype, it is possible to just reflex from chromosomal microarray analysis directly to exome sequencing. Lastly, per the American College of Medical Genetics recommendations, exome testing may be considered as a first-line diagnostic test in a variety of clinical presentations or clinical indications, such as when no single gene or panel tests are available, if there's simply too many genes to test sequentially, or if the past genetic testing has been uninformative. Next, I wanted to talk about the general exome testing process. And in most cases, exomes are typically done in the context of a trio. That is, the proband or the affected individual, along with exome sequencing of the father and mother. And after Sanger sequencing is done to confirm the presence of any detected variants, the next step includes the data analysis step, where the information from the sequencing is filtered bioinformatically to make it a manageable data set to review. The third step involves the interpretation and assessment of findings, which is a manual interpretation of both variants and mutations identified from the sequencing event themselves. The fourth step then is to consolidate all of this interpretation and assessment into a comprehensive analysis, which results in a primary report that is then sent back to the clinician. A fifth step is any possible reporting of secondary findings. So if secondary findings results may not be related to the original clinical indication. For example, if a pediatric patient has been referred due to developmental delays, but the analysis shows that there may be other causes or other symptoms such as musculoskeletal symptoms or cardiac problems, the utilization of exome sequencing can provide information about the mechanism or the etiology for the other symptoms that are picked up. The final step in the exome testing process is the follow-up genetic counseling sessions or discussions with a clinician in order to inform and educate patients or family about the exome test findings. Next, I wanted to share a little bit of information about some peer-reviewed literature that shows the diagnostic yield from exome sequencing. So this is from a paper by Farwell et al. In 2014 in the journal Genetics and Medicine. And so what this study found was in a cohort of 500 patients, the diagnostic yield was 30% to identify a causative mutation for an inherited or rare disease. And for this following table, it shows how exome sequencing can be associated with a particular clinical indication that's identified, as well as secondary findings that in which the exome sequencing revealed a possible causative mutation. Lastly, I wanted to show a comparison of the exome testing pathway, and in this particular example, it will be for neurodevelopmental disorders. So this is a figure that's adapted from the Association of Molecular Pathology, or AMP's, cost-value project overview for utilization of next-generation sequencing technology in clinical diagnostics. So on the top side, what we have is for patients who have an undiagnosed neurodevelopmental disorder, the standard workup includes cytogenetic testing, radiology workup, laboratory and biochemical tests, as well as any single gene test or gene panels in order to diagnose the cause of this particular NDD. After all of the testing is completed, if a genetic cause is identified, then genetic counseling is indicated to counsel the patient and family. And however, if no genetic cause is identified, follow-up testing with other tests is then indicated. Now, for the AMP cost model, what they did was looked at the analysis of the whole exome sequencing pathway as an early or frontline testing option. So in cases of patients or pediatric patients with the NDDs, whole exome sequencing is performed upfront along with Fragile X testing. And in this diagnostic paradigm, if a genetic cause is identified upfront, then the genetic counseling is indicated. However, if no genetic cause is identified, then a follow-up test would be the chromosomal microarray analysis. And depending on the results of the chromosomal microarray analysis, if a genetic cause is identified, genetic counseling is indicated, and if no genetic cause is identified, additional follow-up tests are then indicated. So the overall cost model from the Association of Molecular Pathology just shows that there's potentials to reduce the overall laboratory spending costs by performing whole exome sequencing upfront. And at this point, I would like to go ahead and pass the presentation over to Julie Cohen, who will take us through some case examples of how whole exome sequencing has been utilized in the clinical setting.
Great. Hi, everyone. Thank you, Eric. Thank you, Nancy, for setting me up here. So as we said in the beginning of the introduction, I'm a genetic counselor. So I'm going to speak to you from the clinical perspective, and also I'm going to share with you the patient and the family perspective. So patients and families come to our office asking why. They ask, why can't my child speak? Why was my child born this way? Why isn't she growing? They ask, why are my muscles getting weaker? Why am I losing my balance? We can give them diagnoses like intellectual disability or cerebral palsy or ataxia, and those describe their symptoms, but those diagnoses don't get at the underlying question as to why they have what they have. And we know there are many benefits to knowing the underlying cause. First and foremost, there could be a treatment. There could be something that we do differently to stop their disease, to change the disease course. Even in the absence of a treatment, knowing what the underlying cause is we can tell the patient and the family more about prognosis, about what to expect in the future. Is this a condition that's going to be stable? Is this a condition that's going to get worse? Or is it going to get better in the future? Also, knowing the underlying cause allows us to tailor the patient's medical management. Even if there's nothing we can do treatment-wise to change the course of the disease, are there things we can do to make the outcome better or to watch out for other complications? When talking about a genetic condition, also this brings into play recurrence risk. Is this a condition that's inherited and other people in the family could be at risk to be affected for or pass on? And then also there's psychosocial benefits to knowing the cause and having a name, being able to connect with other people with the same condition, being able to connect with support groups, having better access to services. A lot of times a specific diagnosis is needed to get certain services. And then just peace of mind for the families. So we know that these all can be the benefits, but there's also a number of misconceptions when it comes to genetic testing. One misconception is that if it's genetic, there's nothing you can do about it, so who cares? Or that unless there's a cure, unless there's that magic pill, treatment doesn't matter. Another misconception we hear a lot is that the only reason to do genetic testing is for reproductive planning. So if a family isn't going to be having any more children, or if the patient, him or herself, isn't going to reproduce, then it doesn't matter what the cause would be. And also a misconception that I'll address today is that genetic testing can be a fishing expedition that is very costly and can be very lengthy. These misconceptions, particularly the first three, they reflect a narrow view of clinical utility. Recently, a few months ago, the American College of Medical Genetics and Genomics put out a position statement addressing clinical utility of genetics and genomic services. This statement is useful because it clarifies how we should be thinking about clinical utility and that we need to be thinking about it more broadly, that clinical utility needs to take into account effects on diagnostic or therapeutic management, implications for prognosis, health and psychological benefits to the patients as well as to the relatives, and the economic impact on healthcare systems. This policy statement also reminds us that clinical utility must take into account the value a diagnosis can bring to the individual, to the family, and society in general. And that bigger picture, the society in general, what that's speaking to, also something that we don't always think about is that the importance of establishing a diagnosis to further research in general to develop new treatments and new therapies. That even if there's not a treatment today, if we can identify patients with a disease, then in the future treatments can be developed. So knowing the benefits of understanding a cause, families and patients, they set out on the diagnostic odyssey. And I think this picture really captures what that experience is like for patients and families on this vast ocean of trying to figure out what is going on with themselves or with their child, feeling lost and not having anywhere to go, and that it can be a very long journey. One of the reasons why this odyssey can be so long is because of the vast number of genetic disorders there are, particularly with some of the phenotypes or clinical disorders we're talking about today. There's many, many hundreds or thousands of genetic diseases that can cause that. OMIM stands for the Online Mendelian Inheritance in Man, which is an online catalog of known genetic disorders. And what I did to try to estimate how big this problem is I searched in the clinical synopses with certain keywords, with myopathy, ataxia, microcephaly, seizures, intellectual disability, and developmental delay, which are some of the most common some of the most common indications for undergoing genetic testing. And what these numbers shown here on the bars is the number of known genetic diseases to date that can cause each of these features. So as you can see, there's just an enormous number of possibilities. Over 1,000 known genetic diseases can cause intellectual disability or developmental disorders. And many of these don't have specific features or symptoms that would allow a clinician to perform targeted testing. So we're left with this huge number of possibilities and without a great strategy for how to identify that. So this previous approach to genetic testing is sometimes referred to as the Phenotype-First Approach. Phenotype means the observable signs and symptoms of a condition. So in the Phenotype-First Approach, we take a patient who has symptoms of, let's call it ABC syndrome, and then we order testing for ABC gene. We can find a mutation in that gene and have a diagnosis of that syndrome. That works well and great when you have a good idea of what syndrome your patient has, when they have specific features that allows you to do targeted testing. However, this phenotype approach is very difficult for phenotypes or disorders that have wide genetic heterogeneity, meaning many genes could cause that phenotype, or for disorders where there's not specific features to guide testing. Another challenge with this approach is how do we really know the true spectrum of a condition if we're only ordering the test in patients who have all of the symptoms of the disease? Exome sequencing has allowed us to flip this approach, and the current approach to genetic workup that we can do with exome sequencing is the genotype-first approach, meaning we have a patient who we suspect there's a genetic cause for their symptoms, so we perform genomic or exome sequencing to identify all or almost all of their variants, and then we can narrow that down and pinpoint to a variant in gene XYZ, and then we have a diagnosis of XYZ syndrome. This unbiased approach has many advantages, as I'm going to show you in the cases, that it enables us to diagnose atypical presentations of known diseases. We can diagnose patients early in disease course before all of the features are present, and we can diagnose multiple genetic disorders in one patient. So exome sequencing has now been around for a couple years, and a number of studies have looked at how effective this is in attaining diagnoses. This is a study published in 2014 in Science and Translational Medicine that performed exome and genome sequencing in 100 families with neurodevelopmental disorders. And in this study, in 45% of families, they identified the causative mutation, which is a very high percentage compared to previous testing. But more than that, however, not just what percentage of the time they could identify the cause, is when did it change the patient's management, because that's really what matters. And impressively, in this study, they found that having a genetic diagnosis changed the patient's management or the clinical impression of the disease in almost half, in 49%. And I've listed here some of the ways in which it has changed. And in 1/5 of cases, and 20% of cases, there was a new treatment that was implemented. Sometimes there was a treatment that was discontinued. It allowed the clinicians to search for other aspects of the condition, or it changed the impression of the nature of the patient's disease, and also a number of other potential ways that management was impacted. So this was a really powerful study. We did a similar retrospective study in our patient population at the Kennedy Krieger Institute, and we performed a retrospective analysis of our first 78 completed cases that had undergone exome sequencing among patients with pediatric onset neurodevelopmental disorders, such as autism, intellectual disabilities, cerebral palsy, etc. We looked back over our first 78 completed cases, and we characterized the clinical features, the diagnoses, and the impact on patient management. And what we found was that in 41% of our original cases, we did obtain a definitive positive diagnosis by exome sequencing. And many of these were patients who had undergone previous extensive negative testing. Interestingly, in 44% of our positives, targeted testing of the causative gene wasn't available at that time. So even if we, the clinicians, had thought of our patient has ABC syndrome, a test for that gene wasn't available, so exome sequencing would have been the only way to make the diagnoses. And interestingly also, since publication, 4 of the cases that were originally negative or uncertain have become positive based on new gene discoveries or validation. And what this speaks to is that another advantage of exome testing is that you're generating data and all of this information in the variants, and that isn't going away. And you can potentially look back at that genetic data to identify when new genes are discovered, as opposed to having to order a new test. That data is already there. So moreover, more than just what percentage of the time did we get a diagnosis is what was the impact on the patient's management. And we found that in 100% of our positive cases, there was utility in the diagnosis. For many families, it did impact reproductive planning, either for the parents of that child immediately or for the siblings who would be planning on having children in the near or distant future. In 22% of cases, the diagnosis changed what we assume to be the inheritance pattern, which has big relevance for genetic counseling. In 31% of cases, the diagnosis drastically altered the prognosis of what we thought this child had. and I'm going to give you an example of how that can be really significant. In 19% of cases, having a diagnosis prompted us to look for other aspects of that condition, other manifestations that we wouldn't have otherwise anticipated, so checking the heart or the kidneys, depending on what the diagnosis is. In 16% of patients, based on their diagnosis, we initiated monitoring or screening for future complications of the condition based on what we know about how it could affect. In 16% of cases, we discontinued a medication that the child was currently on because it would either be harmful or we know it wouldn't be effective. In 6% of cases, we started a new medication. And in 9% of cases, we identified a diagnosis for which there was a clinical therapeutic trial going on at the time that the child could be eligible for. So as you can see, more than just how often we were able to figure out the diagnosis, you can see that in all cases there was utility in having that diagnosis. And if you exclude the first two changes that I've listed at the top, which arguably really aren't benefiting the patient, just for the family, still in 59% of our patients, knowing the diagnosis changed something about how we were caring for the patient at that time. Now I'm going to go through 5 cases to illustrate how it can affect a patient's management. So this first case is a 4-year-old girl who presented before 1 year of age with failure to thrive, and she had signs of autism and global developmental delay, and she was first evaluated at our institute when she was about 1.5 years. Her early motor milestones were normal, but then after she turned 1 year old, she kind of slowed down in her development, in her motor development. And starting at around age 2.5, she actually developed loss of her motor skills. She developed very increased muscle tone, what we call dystonia and epistotonus. On examination, she was non-dysmorphic, and her family history was non-contributory. Her parents did not have any other children, and there were no similarly affected relatives. So we initiated a workup, and one of the first steps we do in the neurology clinic is obtain a brain MRI. And her first MRI when she was 1 year, 10 months was normal, and her second MRI at 3 years, 2 months was slightly abnormal. There was some slightly increased signal in the deep part of her brain, shown here, highlighted with the yellow arrows, which is not a specific finding, but it did grab our attention. Since the MRI didn't give us a specific diagnosis, we embarked on the workup. We started with a SNP chromosome microarray and Fragile X, which is the first-line test for all children with developmental disabilities. Those were negative. We tested for Rett syndrome, which is a specific genetic disorder that's common in girls. That was negative. We screened for a whole range of metabolic diseases. We tested for mitochondrial DNA. She had some invasive procedures. We performed a lumbar puncture to measure her cerebral spinal fluid to look for some of the chemicals in her spinal fluid. And she had a muscle biopsy. And the only finding out of all of this that was not entirely normal was on her muscle biopsy. Her mitochondria, which are the energy factories inside of her cells, did not appear to be normal, shown here in this picture. So this, again, still didn't give us a specific diagnosis, and she was really getting worse at this point. And so we sent off exome sequencing, and we were quite surprised when her result came back with a mutation in a gene called PANK2 that causes a recessive disease called pantothenic kinase-associated neurodegeneration, or PCAN, which is a mouthful. This is a terrible progressive neurologic disease where iron builds up in the deep structures of the brain. And in retrospect, her features fit well with it, her increased muscle tone and the regression she had experienced. But we wouldn't have expected this diagnosis because if you look in the literature, all people with PCAN are described as having what's called the eye of the tiger sign on their brain MRI, illustrated on the left picture, that those abnormal signal in the deep part of the brain, and compared on the right to our patient's MRI. So not even the most brilliant neurologist would have ever thought to test for this disease in our patient because she didn't have that eye of the tiger sign, and yet this is her diagnosis. And this diagnosis had a huge impact because it altered her prognosis. This little girl who started out as a girl with autism, we see thousands of children like her each year at our institute. She actually has a fatal degenerative disease. And this allowed us to provide anticipatory guidance for the family. It was a devastating diagnosis, but it allowed them to plan for the end of her life. And they decided that when the time came, they were not going to take heroic measures or do any more invasive procedures, and they opted for comfort care or hospice care, which was, again, devastating and tragic, but it was the right thing for this family to do. And from an economic perspective, you can also think about how that would save healthcare dollars now that we know that if there's nothing you can do to alter the disease course, and if the child is going to pass away, to not try to prolong her life with with treatments or surgeries that aren't going to do anything. We also discontinued some of the medications she was on, thinking that she could have a mitochondrial disease when she does in fact not. And this was also quite relevant for the parents because it's the recessive disease associated with a high recurrence risk. What we learned from this case is that exome sequencing can facilitate a diagnosis earlier in the disease course before all the features are present or with atypical presentations. It can shorten the odyssey and avoid red herrings. And most importantly, I hope this case teaches you that there can be utility in establishing a genetic diagnosis, even if nothing can be done to alter the disease course. In the next case is a 3-year-old boy with muscle weakness who we saw him, and he walked at age 1 year but was unable to run or climb stairs at age 2. He had a Gowers maneuver, which is a manifestation of weakness. He was adopted, so there was no information about his family history. He had an elevated CK, which is the muscle enzyme, and previously he had been tested for Duchenne muscular dystrophy. That was normal. So this is a boy who very likely has a congenital myopathy or a muscular dystrophy, but there are many different types, probably over 100 different genes. So when we considered what are our testing options, we could do a muscle biopsy. That's an invasive procedure that would require general anesthesia for a child. It costs thousands of dollars and still would not give a specific genetic diagnosis, but it could help narrow the differential diagnosis. We could do sequential gene testing, start with one type of muscular dystrophy and move to the next and the next, which if you get lucky and pick it up on the first guess, then that might be less expensive, but you might end up doing sequential gene tests for many months or many years and never find the answer. We could do a gene panel that looks at multiple genes all at once, which in some cases might be appropriate, but also consider that if your gene is not on that panel, it might not be the best approach to go. Or we could do exome sequencing. This family was self-pay. They did not have insurance in the United States. And so they asked us, what if we're going to do one test, what should we spend our money on? And we advised them exome sequencing. And what this found is that he has a mutation in a gene called lamin A that causes a form of limb-girdle muscular dystrophy that causes slowly progressive muscle weakness but also affects the heart. The impact of this diagnosis is it altered his prognosis. He is going to have muscle weakness, but he also has a high likelihood of cardiac involvement where the heart muscle is weak or the heart rhythm is abnormal and sudden death is common. So he can have surveillance by annual cardiac evaluations to catch early signs of that and intervene, such as with a pacemaker or a transplant. And also we can offer him treatment with corticosteroids, which in this type of muscular dystrophy has been shown to slow down the weakness. What we learned from this case is that exome sequencing can be used as a first-line test, and it can obviate the need for invasive procedures. Our next case is a 10-year-old boy who presented with ataxia and low muscle tone and learning disabilities, and his MRI showed abnormalities in the back of his brain. He had an extensive workup over the years that included a chromosome microarray, an ataxia gene panel, many single-gene tests, and metabolic tests that were all negative. And so after many years, exome sequencing became available, and this is the test we ordered for him. And he came back with mutations in a gene called ADCK3 that causes primary coenzyme Q10 deficiency, which is a form of mitochondrial disease. The impact in this diagnosis is that we began treatment with oral coenzyme Q10, which is actually available over the counter. And also this allowed us to screen for other systems that could be involved in mitochondrial disease, such as the heart and the endocrine system, the eyes, and the ears. What we learned from this case is that, number one, sometimes there is a specific treatment for a genetic disease, and number two, that there are limitations to gene panels. This boy has ataxia, but it happens that the gene that's causing his ataxia was not on the ataxia panel, so we did not find it previously. This next case is a boy with global developmental delay and learning disabilities who was born with extra fingers on each hand and had some subtle facial dysmorphism and was small for his age. Previously, he had a SNP array Fragile X, screening for metabolic disorders, and an MRI that were all unremarkable. His mother had some similar facial features and also polydactyly, but didn't have any learning disabilities. So after this extensive previous workup, we had suggested exome sequencing, and this came back showing a mutation in a gene called SETD5 that had just a few months prior been published for the first time in the medical literature as a cause of intellectual disability. And people with this form of intellectual disability, there's some other features that are common, facial dysmorphism, growth delay, and polydactyly, which he has, but also heart defects had been reported. So based on this diagnosis, we referred him to cardiology for an echocardiogram. And despite having no heart murmur on our physician's exam, he actually was found to have a partial AV canal defect and within 2 months underwent open heart surgery. What this case shows us is that exome sequencing can enable the diagnosis of a newly described disease gene for which clinical testing is not available, and it illustrates that knowing a diagnosis prompts us to search for other aspects of the disease that we didn't otherwise anticipate, and sometimes this does. We do pick up things we didn't see before. The very last case is a boy with global developmental delay and low muscle tone and cerebral palsy and some subtle dysmorphic features whose MRI was pretty much normal. He also had an extensive prior testing before the availability of exome sequencing, including multiple MRIs and a lumbar puncture. And after his very long odyssey, never finding a cause, we went with exome sequencing, and he was found to have a mutation in a gene called SETBP1 that causes what's usually a very severe genetic disease called Shinzo-Gideon syndrome, where the children have quite distinctive facial features, birth defects, severe developmental delay, seizures, and many pass away early. We never would have considered this diagnosis for our patient because he's quite relatively mild compared to the previously reported cases, but actually his facial appearance does resemble these babies shown here, and so he does fit within the spectrum of this disease, just much milder than what's been described before. An impact of this diagnosis for him is that this syndrome is associated with an increased risk of certain benign and malignant tumors, and so we initiated screening by ultrasound and blood tests every 3 months. And what this case illustrates is that exome sequencing can enable diagnosis of mild or atypical cases. So lastly, I want to speak to you about the cost effectiveness of exome sequencing. As you could see in the cases I already presented, that for many of these patients, they've undergone many, many tests already that adds up to many thousands of dollars. And I also acknowledge that exome sequencing does have a large price tag associated with it, though that cost is coming down. But if you think about being able to do one test rather than many tests, exome sequencing can be cost effective. The paper I presented earlier by Soden in 2014 in Science Translational Medicine, they also looked at the cost effectiveness. And what they found among their non-acute patients who had been tested, that the mean cost of prior testing was $19,000. The mean number of previous tests or panels was 13. And they calculated that assuming a 40% rate of diagnosis, that exome or genome sequencing could be cost effective at $7,640 per family, which again, I acknowledge is a large price tag. But if you consider the cost of other tests we might do, and also considering the cost of some non-laboratory tests, things like brain MRIs and muscle biopsies, many, many doctors' visits, how if we can establish a diagnosis by one test early on in the odyssey, how that in the long run could save healthcare dollars, and of course, improve patient management. So in summary, I hope that I've shown to you today that exome sequencing is efficient and has a high yield, and if utilized early in the process, can be cost effective. Most of all, that the results impact patient management even in the absence of a cure or a direct treatment, and that there are many advantages to a genotype-first approach by exome sequencing. And so with that, I will turn it back over for question and answer time.
Okay, thank you, Nancy, Dr. Lin, and Julie for such an informative discussion and presentation. On my end, this is very informative, and I'm going to see if we have any questions. Again, for the audience, please feel free to type in any questions into the Q&A box. It looks like we have a couple minutes for questions, and we can get started with those in just a second. Okay. Like the first question, and I'll read the question, and maybe this may be a question for Nancy or Dr. Lin. The first question is, who is typically or / appropriately ordering this type of testing? So which I think they're asking more, what type of providers are most typically or most appropriately ordering this testing?
Oh, okay. I think that's a great question, and I'm not sure of the mix of participants we have out there today, but particularly thinking from an insurance perspective, I know that directors get many, many types of requests across their desk every day, and it's a huge challenge to know when appropriate requests are being made and when requests that require further investigation and time have come across. In general, of course, anybody can order an exome, and there are many, many talented providers out there working in the clinic these days who have a wonderful and complete understanding. That said, individuals such as those that we meet via Julie's clinic, geneticists and neurologists, are the types of clinicians that are going to be most familiar with the benefits and limitations of this test, and I think more importantly are going to be most able to quickly provide you with the documentation that you might need that would enable you to make a fast decision. So if you're looking at a large list of requests or a request for whole exome, and you see that the requesting provider is genetics and or neurology, those might be ones that you could fast track or communicate directly with the office to ask for specific documentation to hopefully enable our clients or the patients to get access to testing in a more timely fashion. As Julie's wonderful presentation demonstrated, getting a diagnosis in a timely fashion is actually quite important for these cases. Some of these conditions are degenerative. Some of them require continued hospitalizations and or investigations. And knowing exactly what it is we're dealing with can have a very immediate and profound impact on management.
Thank you, Nancy. And it doesn't look like we have any more questions at this point. If there are any more questions, please feel free to enter them into the chat box, or you can always email us directly at info@ambrygen.com. And thank you, everyone, for joining us.